Assalamu alaikum. Good morning, good afternoon, and good evening. Today we're going to talk about stroke. Very important. Whether you're doing NACOSKI or MCQ1, this is the topic that you need to know. And by the way, you have access to the notes and MCQ1 and also in NACOSKI. So today we're going to talk in general about the stroke because this is going to be 100% it's going to be in the exam, either in MCQ1 or in NACOSKI. So NACOSKI, it might not like 100% be in the exam because it's a little bit um, hard to deal with it when it comes to NACOSKI, considering the time, but you never know. It might be there. And if it is there, most likely it's going to be there with a chief complaint of dizziness. Since today we are covering a few scenarios about dizziness, we need to know about the stroke before we move on and do some cases. Okay, so I'm going to give you guys like in general information about a stroke. So stroke obviously is a sudden neurological deficit caused by a vascular issue leading to CNS infarction, while transient ischemic attack or TIA present transient symptoms without lasting damage, resolving completely. So in terms of epidemiology and stroke types, and we need to know like basically we have two most common or very popular stroke type. One is ischemic and the next one is hemorrhagic. Pathophysiology of ischemic stroke, which is, as I mentioned before, we have two very popular type of stroke. One is ischemic, one is hemorrhagic. Ischemic is the most common, like 85% of the time, the stroke is ischemic. And the hemorrhagic is 10 to 15%. So, in terms of pathophysiology of ischemic stroke, understanding the mechanism behind ischemic stroke. So, large vessel disease, small vessel disease, and cardioembolic stroke. So, in terms of large vessel disease, atherosclerosis, dissection, and vasculitis contribute to the large vessel disease, resulting in reduced distal blood flow and increasing the risk of ischemic event in affected areas. A small vessels disease like chronic hypertension, diabetes mellitus lead to small vessel or lacunar disease causing lipohyalinosis and vessel narrowing, which can result in localized ischemic stroke in the brain. Now, cardioembolic stroke. Cardioembolic stroke occurs when emboli from the condition like arterial fibrillation, which is the most common reason in terms of cardioembolic stroke. If it is going to be a question in the licensing exam, this would be the question. Like, what is the main source of cardioembolic stroke? It will be um, arterial fibrillation. Valve disease is the second, or myocardial infarction blocks cerebral blood flow, leading to ischemia or ischemic damage in the brain tissue. One more thing that we need to know about pathophysiology of ischemic in general, the difference between hemorrhagic and ischemic stroke. When the ischemic stroke happens, the patient gets worse, then the patient gets a little bit better, and then the patient stays that way. Okay, like let's say if this is the graph, the patient gets worse, then the patient gets a little bit better, and then the patient halfway gets better. Like this is the normal range, right? So it goes down, gets worse, and then the patient gets better with the treatment and does not get cured all the way. So the patient is gonna stay here. But in hemorrhagic, the patient gets worse, 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 and worse, and rapidly. It's getting worse. So the graph is dropping very rapidly and it never comes back to normal. And it's very dangerous comparing to ischemic. So mechanism of hemorrhagic stroke result from the blood vessels rupture, leading to bleeding within the brain like this. cause chronic hypertension, trauma, and amyloid angiopathy, highlighting the importance of early recognition and management. So in that case, we need to recognize it earlier and take care of it. Okay, this I think we did mention this. Yeah, we did. I don't know why it just came back. Okay. Gender presentation. So a stroke presents with a sudden neurological deficit, including weakness, speech disturbance, and vision loss. Other symptoms may include headache, nausea, altered mental status, change or consciousness, particularly in case of hemorrhagic stroke, and also dizziness, which I forgot to put. Oh, this is the most important slide. This one, and this one. These are the affected area. So clinical feature by the vascular territory, by the area that it caused the stroke. So anterior cerebellar artery, if this area at territory is affected, the patient will have contralateral leg weakness or sensory loss. So it is more in the leg than the arm. I mean, the lower limbs are more affected than the arm. Cognitive behavior changes such as apathy, poor judgment, and confusion. So it is very hard to remember because in MCCQ1 or in NAC-OSCE, in MCCQ1, they will provide you with a scenario, and then you should be able to pinpoint the vascular territory or the area of the brain that is damaged or affected by stroke. For example, they will give you a scenario about somebody that who had a stroke and the patient has more on the lower side or contralateral side leg weakness comparing to the upper side, and also the patient has apathy, the patient has poor judgment, and the patient has confusion. And there will be options. So which area is more affected? Is it anterior cerebral artery? Is it the metacerebral artery? Or it is, for example, so on and so forth. So obviously, you know, this is in the left side. So contralateral is on the right side. The leg is affected. So it is the anterior. How to remember this? Or this could be part of the past encounter in NAC-OSCE. For example, your patient had this symptom. Which part of the brain is affected? Then you should be able to say this is the arterial cerebral artery or anterior cerebral artery. So now how should we remember? It's very hard. It's hard, but it's not impossible. So remember, when we are walking, the foot is always going forward. So anterior, remember this way. Leg is always going forward unless you're walking backward, which we never do that, right? We always normally walk forward and always the leg is going forward. So this is how you can remember it. If the leg is going forward, so it is anterior cerebral artery. And since it is anterior, so the frontal area is also affected. So the frontal is also affected, which the judgment and also the apathy and confusion will be positive. Now let's go to the metacerebral artery, contralateral weakness and sensory loss, but in this case, it is more on the upper side. Since it is middle, so it is face. It is face and arm more than lower limbs, or upper limbs more than lower limbs. Not only that, the visual field deficit will be also positive, and the dominant hemisphere, usually if it is the dominant, the patient will have aphasia. If it is non-dominant, it will be neglect. So they will give you a scenario about someone that who has not only facial weakness, the patient also has, let's say, arm weakness. So the affected side is on the left side, right? So if contralateral loss of sensation and weakness is on the right side, so it is on the left side. So this side is dominant. Why? Because we are right-handed, unless you're left-handed. So in that case, the patient will have aphasia. But if it is on the right side, which is non-dominant, the patient will have attention deficit. In that case, the patient will neglect the other side. Neglect like he is not shaving the contralateral side, or he is not even caring about the left side. For example, he's ignoring the whole left arm. It's not mine. Or he's shaving the right side, but just ignoring the left side. Now, the posterior cerebral artery, and one more thing which I made it bold, is the deviation, gaze deviation often toward the lesion. If the lesion is on the right side, so the eye will be gazed or deviated to the right side. If the lesion is on the left side, so the eye will be deviating to the left side. So posterior cerebral artery, contralateral hemianopia, quadrantanopia, can have thalamic involvement causing sensory deficit, amnesia, altered concussion, and this one also will have dizziness. So usually if they give you a scenario about this and with a chief complaint of dizziness, that could be one of the reasons. Bilateral PCA involvement, cortical blindness, and prosopagnosia. All right, this is very small. Basilar artery can cause severe brain syndrome, dysarthria, ataxia, ocular movement abnormality, and quadriplegia. Severe forms include the lock-in syndrome and coma. So commonly tested, out of all of them, commonly tested is the basilar artery. They will give you a scenario about somebody who has a stroke and he is quadriplegic. Which artery is causing most likely quadriplegic? That will be the basilar artery. Not only that, the lock-in syndrome is very specific for basilar artery. So remember these two things. The PICA, lateral medullary and Wallenberg vertigo, another type of stroke that will come with the chief complaint of dizziness and vertigo, nystagmosis, nausea, vomiting, dysphagia, dysarthria, hiccups, ipsilateral facial sensory loss, and Horner syndrome. So if you have these, especially the dizziness, nystagmosis, hiccups, and also if the patient has Horner syndrome, always think about PICA. And medial medullary anterior spinal artery, contralateral hemiparesis for the middle medullary anterior spinal artery. So you will have contralateral hemiparesis, often face sparing. This is the key word. They will give you a scenario about someone who has contralateral hemiparesis, but the only thing is that the face is not affected. The face is not affected. Contralateral loss of proprioception and vibration. This will be also part of it. And ipsilateral tongue weakness. Same side that's affected, the tongue will be weak. So the tongue will deviate it to the opposite side. Since this is weak and that part is affected, so it will deviate to the opposite side of the affected, so the contralateral side. Ipsilateral will be weak, but the tongue moves away from the affected side. Lacunar syndrome, very characteristic finding is pure motor weakness or pure sensory weakness. If you have somebody with a stroke who has pure motor weakness or pure sensory, then think about lacunar syndrome. So these are all the information about the affected area of the brain or vascular structure affected area, and the sign and symptoms, which you guys have it in your account. So you can go over it fast. There's a mnemonic about stroke, which is fast. F stands for face dropping or weakness. And A stands for arm weakness, S stands for speech trouble, and T stands for time to act. It means you need to call 911. It is usually part of the first aid, and people that who can recognize a stroke as soon as they see it, and what would be the next step. I doubt it if they ask you this because it's part of the first aid, but it's not bad to know it. Immediate stroke assessment, conduct ABC, check vitals, monitor glucose level. So I can tell you that one of these will be part of the immediate investigation or management plan as soon as you see a stroke in the ER or hospital. So as soon as you see it, remember that you need to start the ABC, you need to check the vitals, but remember, monitor glucose level. I have seen it in so many question banks that they might even they might ask you, and that would be the right answer. So they randomly put other stuff which are not the part of the immediate actions. For example, start, for example, this and that. So they give you something that you need to do as a secondary or as a second or third step. And then the first step would be to check for the blood glucose. Why? Because hypoglycemia also happens to mimic exactly the same picture of a stroke. So you need to check the glucose as soon as possible. Okay. Now, when it comes to imaging, which is commonly mistaken by IMGs, they go after CT scan with a contrast. Please don't do that. It is perform non-contrast CT scan to exclude hemorrhagic stroke. That is very commonly tested. What is the best imaging for the stroke? Non-contrast. And NIH stroke scale to evaluate neurological deficit. Um, I'm not saying they're not going to ask you, but usually the non-contrast will be very commonly tested. And CT angiography, if they are actually asking you specific about visualizing large vessels occlusion, then you can do the CT angiography. MRI, detailed assessment of stroke types and location. So pay attention to the wording. This could be the pause and counter question of examiner after you meet or after you visited your patient in the DAISY station or a station that the patient had dizziness or a stroke or whatever. This could be part of that, or this could be one of the questions in the MCQ1 licensing exam. So pay attention to the wording. What is the first best imaging? Non-contrast CT scan. What is the best choice for visualizing large vessels occlusion? CT angiography. Which one of the following is used to provide detailed assessment of the stroke time and location? MRI. Okay, so pay attention to the wording. This could be one of the questions in the MCQ1, or it will be raised by the examiner as a part of the post encounter in the DAISY station. Pay attention to the wording, okay? If you do not understand, ask the examiner to repeat it. Please repeat it one more time before you answer. Before you answer it wrong, make sure that you understand the question right, okay? Now, if you guys remember, I mentioned that one of the immediate investigation that we need to do is glucose. And that's why we check for glucose. Why? Because there are some conditions that mimic a stroke, and they almost, in terms of clinical feature, they look the same or they look alike. For example, hypoglycemia can present with confusion. Confusion and weakness symptom. Infection That's why we do the CBC to see if the WBC is high, if there's leukocytosis positive. And migraine, severe headache can mimic stroke presentation as well. Now, management of the acute ischemic stroke. Trauma management and vast supportive care, thrombolysis, if it is less than 4.5 hours. If it is more than that, within 24 hours, thromboembolic, or even if it is before that and there is no way that you can get your hands on the thrombolysis, then you have no choice. And yeah, antiplatelet therapy to reduce the risk of further stroke. Thrombolysis, restore the blood flow if administered timely. When I say timely, it means less than 4.5 hours. Thrombectomy, mechanical removal of the clots via catheter techniques, if it happens, or if it happens that you get the patient, but it is over 4.5 hours, or there's no way that you can get your hands on any of those thrombolysis within 24 hours. Okay, antiplatelet prevent further clots post-ischemic event. So this is the treatment algorithm or flow chart that how you started. So basically suspect acute stroke. So code stroke should be activated, maintain glucose. Remember that we have to check for the glucose, hydration, blood pressure, oxygen saturation, temperature within normal limits. So we have to take care of everything and we have to make sure that they are within normal range. Then ischemic stroke management. If it is ischemic stroke, again, within 4.5 hours, then we have to, the patient is eligible for thrombolysis. And if it is not, then mechanical. So administer this if it is a good candidate. Now for the hemorrhagic. For the hemorrhagic, remember that we need to control the blood pressure. We shouldn't bring it too low and we shouldn't keep it too high. So it's supposed to be this systolic blood pressure is supposed to be kept less than 140 to 160, less than that. Reverse anticoagulants and consider correcting coagulopathy, referral for urgent neurosurgical assessment. And antiplatelet, the rest you guys know. Blood pressure management, I did mention it before that we need to control the blood pressure, especially if you're dealing with a hemorrhage, and we need to keep the blood pressure systolic less than 140 to 160. Emergency management of hypertensive encephalopathy, prompt recognition and control of the blood pressure are vital. Utilize IV agent to rapidly lower the BP while assessing for end organ injury and ruling out other serious condition. All right, complication of a stroke, key issues, common complication following a stroke, including early seizure. This could be in the licensing exam. Hemorrhagic transformation, cerebral edema, raised intracranial pressure, which can significantly affect recovery and requires prompt attention from healthcare professionals. Prognosis, the outcome of a stroke depend on multiple factors. It is not just if you have the stroke, you have the poor prognosis. So including the type of seizure. Is it ischemic? Is it hemorrhagic? Because I told you guys that hemorrhagic is very rapidly getting worse, onset time, and intervention. So the stroke happened. When did it happen? Which area was affected? How much was the size of stroke or the damage? How much area has died? How much area has been affected? And also how quickly the patient received the treatment. They all matters when it comes to prognosis. Sorry. Early treatment enhanced recovery and emphasized the importance of timely care and improving patients' prognosis. Now, a stroke center, improving the patient's outcome. Designated stroke centers provide specialized care, ensuring rapid treatment and rehabilitation. Early intervention significantly enhance recovery and reduce disability, emphasizing the critical nature of. So basically, every timing has everything to do with the prognosis. And thank you very much. And now you can admit him